There is the best example. The best example of frameless radiosurgery is the cyber knife. You just put the mask. The best example of the frame-based radiosurgery is the gamma knife, but you should fix the heads with this firm application, because in the cyber knife you have tracking system. There is a camera, X-ray following the movement of the head. In the gamma knife, you don't have a real-time image, so you need to fix it with these screws. This is have an advantage. This is have an advantage. It will take time to compare, but for the young neurosurgeon, look at this photo. You have 21 source of radiation of cobalt. Each single one is very weak to affect the brain. But if all of these meet at the center, they will make an action, they will make a lesion, they will stop the cancer tumors. So this is the philosophy of the cobalts. It's very important for us to know that Lars Lexell was a functional neurosurgeon, and he invented the gamma knife to create a lesion without surgery. Adler is invented the cyber knife. He also was a functional neurosurgeon, and afterwards the radiation oncologist that the original use of radiosurgery was a functional indication. This is one of trigeminal neuralgia. A lot of targets in the literature. We use the safest one, which is the retrogracilean. This is the secondary trigeminal neuralgia. Have a good result with radiosurgery without doing real surgery. This is lesioning, non-invasive lesioning. You can do it by stereotactic radiosurgery, or you can do it by the recent device, which is the high focused ultrasound, eye-guided ultrasound focused technique. You can, especially in very old age, like this, and you have thalamotomy, you use tractography to have more accuracy. This is the patient 3 months, then it stopped because stopped here, but still on the other side because you do the non-invasive radiosurgical thalamotomy stage. You cannot do it bilaterally. This is the hypothalamic hamartoma. A lot of paper in the literature. This is a real case. We treat it by radiosurgery because sometimes the surgical intervention is very risky. This is a stereotactic ablate epilepsy surgery for the hypothalamic hamartoma if it is resistant to the radiosurgery. Okay. This is the cavernoma also. You can on eloquent area. This is the AVM, arteriovenous malformation. You can treat it also by radiosurgery. This is an example, one before stereotactic radiosurgery and one after the stereotactic radiosurgery. You see the blush sign is disappeared after the occlusion of the nidus in the arteriovenous malformation. This is also another example. This is our recent paper about how to use the non-invasive callosotomy in epilepsy in neurosurgery. A lot of varieties, a lot of indications. My advice, as I understand well, this is another paper on the safety of radiosurgery in epilepsy and in the hypothalamic hamartoma we published in epilepsy. Intraoperative monitoring, functional neurosurgery. It is not only stereotactic. This is one of our cases of selective dorsal rhizotomy. It improves the walking abilities in the spastic CB children. This is the device. This is also intraoperative monitoring. We use one of our cases close to the motor area. I have only 2 minutes. I'm about to conclude. I intend to enumerate a lot of indication and a lot of application, because when you master the stereotactic surgery as a tool, you can apply it in very different application and indication. So don't focus on only in single indication. Try to focus on stereotactic as a concept, as a tool, and how you can improve the device, how you can use a different model, a different technique to apply it in different application. And I hope, yes, I'm before the end of the time. I'm welcoming anyone of my colleagues, of the residents, of the students to have any cooperation on research, on clinical activities. I'm honored to be with you. I hope my presentation was brief and was not long. And thank you so much.
Thank you so much, Professor Hussein Hamdi, for the concise presentation on functional neurosurgery. We do have our panelists for discussion. We have Professor Ensley Nico Johannes from who is an associate professor at the University of Cape Town Neurosurgery Department. He's a pediatric neurosurgeon and runs the functional neurosurgery service there. He's the continental vice president for the World STEREOTACTIC and Functional Neurosurgery Society for Sub-Saharan African region, as well as the international chairman of the Surgical Commission of the ILAE. He's got a special interest in surgery for spasticity, epilepsy, as well as movement disorders. And then our second panelist is Professor Ekoyele Mbaki Hughes Briggs, who is the chair of neurosurgery at the Mariam Ngoyabi Hospital, as well as the head of surgery at the University Hospital of Brazzaville, and the Director General of the General Hospital of Njiri, who is also the Vice President of CAANS for Central Africa, and the second Vice President of the WFNS representing Africa. I do welcome my colleagues for the discussion on this topic.
Thank you. Thank you very much for having us. Thank you very much, Professor Hamdi, for your lovely overview talk.
Maybe Prof. Enslin, you can just give a bit of feedback and context in terms of stereotactic neurosurgery within the continent. Both you and Professor Mbaki are quite interested and are experts in functional neurosurgery, so it would be nice if you probably start that talk for us with Prof. Aaron Musari. Thank you.
Thanks. I think it was a lovely talk, and it's a big topic on its own to cover in a short period. I think, in my mind, probably one of the most important things to discuss in the context of Africa is to look at where is their role for such an expensive procedure, sort of set of procedures, because cost is significant. I think you saw from Professor Hamdi's presentations that it's big ticket items. It's sort of the types of items that one often use in functional neurosurgery is basically a whole hospital yearly budgets put into one gamma knife or things like that. To do stereotactic EEG, to place 12 to 15 stereotactic electrodes, your initial setup cost of things that you need costs in South Africa costs exactly the same as to purchase a brand new Lexel Vantage stereotactic frame. So about a million, 1.5 million rand for disposable project if you do stereotactic EEG for one case. So it's important that maybe one discuss that context in terms of how does one warrant that. I think firstly, our patients in Africa don't deserve less than patients in Europe and patients in America. So we should not necessarily see it as it's too expensive, and therefore no one on the continent embarks on these avenues to treat patients with these techniques. I think as functional neurosurgeons, we are privileged to really improve people's function. It's not called functional neurosurgery for nothing. So that the goal would be to ascertain whether one can improve a specific patient's function. And only if you can improve a patient's function with the procedure that you do you continue with it, and do you do it for that patient? So when we speak about spasticity, for example, we don't treat the spasticity just because it's there. We treat the spasticity only if it impairs a patient's specific function. And that function varies. It can be walking on the one extreme, and it can also be for the immobile child, just to allow the parents, for instance, to change the child's nappy if the adductor spasticity is even preventing hygienic care for the patient. Then it is functionally important to treat that patient's spasticity. So if one looks at that as a principle in terms of why it's necessary on the continent, it's absolutely necessary for those reasons. We know with epilepsy, 80% of the world's patients with refractory seizures, refractory epilepsy, is based in low and middle income countries. So they are here with us. They aren't in Europe. They aren't in America. There's a lot of low-hanging fruit, so to speak, in Africa, as an example, in terms of epilepsy. America and to a great extent Europe are having less and less patients with lesion-related epilepsy or MRI-positive epilepsy. And that's why they have to start venturing into these extravagant multiple stereotactic EEG examinations for patients. While here in Africa, the big brunt of epilepsy care is still lesion-related. So those are techniques that should be pretty much easily picked up by many people on the continent. So we can make a drastic difference already in things like epilepsy as well. And like Professor Hamdi has shown, there's a lot of techniques that one can do with radiofrequency lesioning still. And those are very cost-effective procedures. You do not need to think about functional neurosurgery as expensive deep brain stimulation electrodes that can become septic or costs a lot of money to implant every few years as the battery runs out. You have to replace the battery. A lot of those patients can be treated very effectively with lesioning techniques. And radiofrequency lesioning is much more cheaper than gamma knife surgery, as an example, and very, very effective still. Same with psychiatric surgery. The lesioning techniques there is also extremely valuable, and there's no reason that we do not practice them in Africa. I think just lastly on my side, forgive me if I take too long, lastly on my side, I think the question that we should speak about is, how does one start? And I think the important thing, like Professor Hamdi has said, the principles matter. So start by understanding the principles of stereotaxis. Sophisticated, meticulous planning is incredibly important. So understand the principles, understand the techniques, use those principles to improve biopsy results, as an example. Use those principles in accessing tumors in eloquent areas. Start to use electrophysiological principles and intraoperative neuromonitoring as you treat tumors, which are, the burden is massive on our continent. And then you start building that experience into functional neurosurgery. In functional neurosurgery, every single step matters. So you have to be thorough, diligent. By nature of a group of people that are drawn to functional neurosurgery are pathologically obsessive in our nature. And you have to double check everything and everyone around you. I drive people around me insane by my mistrust of them. It's not on purpose. It's just that obsession of trying to double check everything the whole time. And that's the way, unfortunately, one has to do it, because small errors, small mistakes ends up in catastrophe for patients. So meticulous planning is very important. Check your results. Don't just, if you do a procedure, a stereotactic procedure or a biopsy, don't just be happy that you managed to drain pus from the abscess by doing it, or that you managed to get a biopsy. Check afterwards on your post-operative imaging where your actual trajectory was. go and merge it again with your plan and check. Remember, there's so many different steps where errors come into play when we do stereotactic or procedures, that you only learn by double checking afterwards. If you have a patient that, if you have a trajectory that you can check on a scan, and afterwards you can always see where your track was, whether we want to believe it or not, then go and merge it again and see whether your planning and your end result is exactly the same. That's how one learns. The fact that you planned the trajectory does not mean your electrode necessarily ends up going exactly where you plan. And that's the goal of stereotactic or functional neurosurgery. You must always aim to improve that error rate. The error rate should become smaller and smaller and smaller as time goes on. And that's mandatory for you to double check. Cost-wise, like I said, there's ways around it. I don't think you need to think that you can't do epilepsy surgery because you can't afford a robot and place stereotactic electrodes with a robot only. That's not the way that anyone ever starts out doing this. No one owns a robot from the start. Maybe if you're in Vienna, Christian Dorfer there, maybe he started out off with a robot, but the rest of us mere mortals don't. And you don't need to. But building these basic principles and then learning from that and then building the project from there, I think is a very good way to do. Let me end there, that I don't take too much time.
Thank you so much. Appreciate. Well, that's you gave some insights into this setup, which is very important, and to take away fear of thinking it can be done because the resources are limited and you can't afford a robot. So thank you so much. Let's hear from Dr. Mbaki.
Yeah, thank you. And thank you, Professor Hamdi, for this excellent presentation. I think that functional neurosurgery is the field of precision. It's based on careful planning, stereotactic principles, imaging, and a deep knowledge of functional anatomy. Its applications are growing in movement disorders, epilepsy, pain, and psychiatric conditions. However, when we speak about Africa, the discussion becomes strategic. Our main limitation is not knowledge, it's organization. In many African settings, we face structural challenges: limited imaging access, equipment maintenance problems, financial constraints, and weak multidisciplinary coordination. These realities limit access to care, and many patients who could benefit from functional procedures remain untreated. And so the key question is not, can Africa do functional neurosurgery? But the real question is, how do we build sustainable systems adapted to our context? And we need a paradigm shift. And Africa should not try to copy Western models exactly as they are. And those systems were built in different economic and technological environments. If we copy without adaptation, we risk building programs that are difficult to sustain. And instead, we must start with realistic minimum requirements. We must grow progressively, step by step, with stable foundation. Functional neurosurgery in Africa must be built on robust technologies, good planning, and context-adapted innovation. Equally important is the human factor. Functional neurosurgery requires teamwork, and it cannot exist without collaboration between neurosurgeons, neurologists, radiologists, psychiatrists, and biomedical engineers. Structured training and mentorship are essential for long-term development. I think that, excepted some countries like Morocco, Algeria, or Egypt, and South Africa, no single African center can build everything alone. The future lies in collaboration, regional networks, shared expertise, and coordinated strategies. Professional societies like CAANS have a key role in connecting centers, supporting education, and continental cooperation. That the future of functional neurosurgery, it will depend on organization, and it will not grow through isolated efforts, but grow structured collaboration. If we organize ourselves wisely, precision medicine will become sustainable and accessible for our patients. And it was my opinion about this good presentation.
Thank you very much, Professor Mbake. Thank you for speaking about the need to make sure we adapt and take the technology to an extent where we make it functional. In as much as it's about functional neurosurgery, we want to make it functional for the societies which we are dealing with, something which we can be able to sustain into the future, rather than setting up something which will only run for a year and it can't go on forward. Thank you for that. I think this takes us through the time for the first session, and we'll proceed into the second session. Our second session is a talk which we have from Professor Emeritus Dirk Van Roost on building a functional neurosurgery center, talking about requirements and infrastructure, technology, and the HR issues, training pathways, multidisciplinary models, as well as African expansion strategies. Professor Roost has worked as a neurosurgeon both in Germany and in Belgium. He's a former chair of neurosurgery at the Ghent University Hospital in Belgium. Since his retirement in 2018, he has continued his work part-time with a particular interest in functional stereotactics and epilepsy surgery. He's a former president and currently an honorary member of the Belgian Society of Neurosurgery, a panel member of the EANS functional section, and a member of the executive committee of the European Society for Stereotactic and Functional Neurosurgery. He was a regular lecturer on EANS training courses, a member of 3 other international scientific societies, and a member of International Advisory Board of the CNS Journal of Neurosurgery. Professor Dirk Van Roost, thank you for being available. You can proceed and share your slides.
Thank you, Professor Aaron. Please give me feedback whether my slides appear.
Right. Yes, your slide has appeared. You just need to make it full screen. Yeah, now you're there. Thank you.
Thank you again for the kind introduction. The field of functional neurosurgery I was requested to talk about is epilepsy surgery and building an epilepsy surgery center. In order to cover the requested topic, I will explain the principles, the basic principles of epilepsy surgery, our local workflow, and I will highlight the major role of pre-surgical epilepsy evaluation in the process. Finally, I will share with you some experiences that colleagues from low and middle income countries published about building an epilepsy center. Epilepsy is not a single disorder. It is, moreover, a symptom of a variety of conditions. Refractory or pharmacoresistant epilepsy means that seizures continue to occur in spite of a treatment or treatment trials with at least 2 appropriate anti-seizure drugs at full therapeutic dose. And there are about 30 different anti-seizure medications available. So what are the treatment options for the 30% of epilepsy patients who are refractory? Either new developed anti-seizure medications, a ketogenic diet, or in case of focal epilepsy, resective or disconnective epilepsy surgery. For non-resective epilepsy surgery, there's neuromodulation in terms of vagus nerve stimulation or the brain stimulation. Very often, refractory focal epilepsy is related to a structural lesion. In this example, a hippocampal sclerosis. The structural lesion does not necessarily coincide with the seizure onset zone and can be much smaller than the epileptogenic zone, and this even smaller than the irritative or symptomatogenic zone. By definition, the total removal or the disconnection of the epileptogenic zone is necessary and sufficient for achieving seizure freedom. Seizures can also be described as a brain network disorder. A structural lesion disturbs a local network, which is the epileptogenic network. The epileptogenic network can influence an adjacent network, the propagation or symptomatogenic zone network, while other networks may not be involved. This way of describing originates actually from SEEG findings in a pioneering era when imaging facilities did not even exist to detect the structural lesions. So the goal of pre-surgical evaluation is to identify the epileptogenic zone. However, no single test is sensitive and specific enough to identify this epileptogenic zone. So the brain is being assessed in a number of different ways to form a hypothesis on the location and the size of the epileptogenic zone. The pre-surgical evaluation of epilepsy consists of a graded canon of evaluations, tests, or examinations in which 3 phases are distinguished. A non-invasive one, with medical history taking, video EEG monitoring, neuropsychological evaluation, an optimum of neuroimaging and optional non-invasive adjuncts. A second phase is an invasive phase of diagnostics with, for instance, the WADA test or invasive video EEG monitoring. And finally, the third phase is therapy, which may consist of resective or disconnective surgery or neurostimulation. Phase 1 comprises video EEG monitoring. This is the cornerstone of pre-surgical epilepsy evaluation. This is an example of split screen, a video, now it is not animated, of the epileptic manifestations and the synchronous EEG which are displayed. It allows to verify the precise electroclinical correlation of the epileptic activity, the subclassification of epileptic seizures, and the diagnosis of even non-epileptic seizures. All this is performed in a facility that allows a continuous survey 24 hours in 7 days a week of all monitored patients. And this is at the Department of Neurology of our clinic, equipped with steerable cameras and EEG connection wall boxes. The patients are being observed by cameras, and this is done from a central monitoring room where specialized nurses observe permanently the patients. This is an example of video EEG monitoring where the patient is in conversation with a nurse, explaining to her in which circumstances he tends to have seizures. His talk is suddenly interrupted. Instead, he is now chewing. There's a motionless stare, ipsilateral automatic limb movements like money counting, and contralateral dystonia, which is not so obvious. And being addressed verbally by the nurse, the patient gives only restricted response, which means there is a lowered awareness, perhaps aphasia, which is the typical semiology of left hemispherical mesial temporal seizure. MRI imaging is the second big cornerstone besides video EEG monitoring. The goal is a screening on or the detection of structurally abnormal brain areas that may be related to seizures, such as a gliotic scar, sclerosis, tumor. As a matter of fact, with good imaging, more than 90% of patients are shown to have structural brain abnormalities. However, the epileptogenicity of the lesion should be confirmed. Is it just an incidental structural lesion, or is the visible lesion only part of a true pathological tissue? It has also been shown that higher magnetic field strengths are superior for lesion detection. Nowadays, even 7 Tesla MRI is available. It is a quite expensive facility, about 3 million of euros for the construction and the device, and moreover, maintenance of 300,000 euros per year. And the new tool is subjecting the MR images to an automated morphometric detection of deviations from the average taken from a large database. Non-invasive metabolic imaging consists, for instance, of interictal glucose, PET. The ictal onset zone can be characterized by an interictal hypometabolism and an ictal hypermetabolism. So ictal SPECT can then be done, and it consists of the injection of a radioactively labeled tracer at the very onset of a seizure. Then this tracer is very fast binding to the brain, which gives you a snapshot of this moment in time. However, it can be a logistic challenge to achieve an injection as soon as possible after the seizure onset. Any delay will show the spreading pattern rather than the seizure onset itself. This is magnetoencephalography. It is a diagnostic tool for interictal recording, which is complementary to EEG. The MEG is more sensitive to the electric activity arising from the cortex within the sulci rather than from the convexity of the cortex. In Belgium, the 4 epilepsy surgery centers share one facility, which is located in Brussels. It is a very sensitive device. It is therefore located within a very much shielded Faraday cage, and it consists of 1 hour of recording interictally. This too is a very expensive device, reason why we share it with 4 centers. MEG source imaging reformats the findings into dipoles that in an ideal case then cluster into a single brain area, as in this example, where it is the superior temporal gyrus, the right side. At the epilepsy surgery staff meeting, which we perform every 2 weeks for 2 hours, all phase 1 results are then collected and discussed in team. Is there a concordance of the data? The physicians of all specialties concerned, such as neurology, neuropsychology, neuroimaging, nuclear medicine, neurosurgery, investigate this question, whether the patient is eligible for surgery as such, or an unsuited candidate or not yet defined and needs any further, more detailed examination. Then we enter into phase 2, which is an invasive diagnostic phase. For instance, with a WADA test. WADA test is named after the Japanese-Canadian neurologist Jun Atsushi Wada, and it consists of the injection of a short-acting hypnotic such as Amital or Propofol into the catheterized carotid artery in order to examine the hemispheric language dominance, the reserve capacity of the hemisphere contralateral to the epileptogenic zone in terms of memory, and the possible memory deficit in the hemisphere ipsilateral to the epileptogenic zone. Such a memory deficit may even be in itself a lateralizing indication. And finally, within the invasive phase is also the placement of intracranial electrodes, such as subdural electrodes. It can be done in two ways, either intraoperatively, which means that it is done in the same time as resective or disconnective surgery, or extraoperatively, which means the placement of the grids, then closing, and in a separate time, the resection will be done. It is not necessary in every case, and indeed, invasive EEG has been gradually substituted by the improved non-invasive assessments. If subdural grids are placed, the contacts serve as coordinates that are labeled with their respective roles in the seizure generation, as in this example, the red dots, but also the individual cortical functions indicated by the other colors. These coordinates define the resection borders and will guide surgery. For extratemporal and especially for MRI negative epilepsies, invasive electrocorticography remains quite indispensable. There's also the possibility, and it has been shown by Professor Hamdi, the possibility of placing many depth electrodes, which are stereo EEG electrodes. It may happen that as many as 15 multi-contact electrodes are stereotactically inserted, and they are fixated by cannulated bolts which are driven into the skull. And then finally, we have the therapeutic phase, phase 3, in which either the removal of the epileptogenic zone and lesion are done, here with an example of a selective amygdalo-hippocampectomy, or a disconnection of the epileptogenic zone from the remainder of the brain is to be performed, such as in this case, in the middle image, a hemispheric disconnection, or on the right side, neuromodulation, such as the brain stimulation with a variety of intracranial targets. While the resection or disconnection removes or isolates the epileptogenic zone from the remainder of the brain, neuromodulation acts not only as a brain defibrillator, but it is also something that reduces the kindling of the adjacent networks, thus recalibrating them by stimulation-induced plasticity. And this is an explanation for the fact that outcome improves many times by time. Now, it has been observed that, and it has been calculated that the prevalence of epilepsy is even higher in the low and middle income countries, ranging from 2.5 to even 60 out of 1,000 people. 80% of patients who have epilepsy live actually in lower and middle income countries. I found in the literature a few reports of experiences of colleagues from lower and middle income countries in building an epilepsy surgery center. And this one is from Indonesia. The common feature of these experiences is that the centers in lower and middle income countries were built up in a staged manner and assisted by a partnership or a mentorship from higher income countries. In this case, the Indonesian colleagues were assisted by colleagues from Japan. And so the stage introduction means in the first period, the diagnostic tools are restricted to neurological examination, neuropsychology, interictal scalp, and MRI, no invasive recordings. The surgery is based on seizure-related lesions, which is almost exclusively the temporal lobe epilepsies, and no MRI negative epilepsies. While in a second, more advanced period, the diagnostic tools are expanded to long-term, non-invasive and invasive video EEG with subdural electrics recordings, inclusive functional cortical mapping, PET scan, WADA test. And surgically, the colleagues perform also intraoperative interictal ECOG, awake functional cortical mapping, somatosensory evoked potentials, extratemporal lobe epilepsy, cortical resections, multiple subpial transections, and anterior callosotomy. Another experience is from Uganda, where the colleagues also emphasize the helpfulness of a hybrid remote and in-person collaborative model between teams in the cities of Mbale and Kampala on the one side and Chicago in USA on the other side. They also highlight that the challenges are multifactorial and can be grouped into three categories, which are the human capital, technology, and finally, resource allocation. A last experience I would like to share with you is from Panama, where the colleagues had a collaboration with a team from New York. Here, in the same way, they had a surgical plan 1 in the first 2 years of building up this center, which consisted of resections or disconnective surgery, with or without intraoperative electrodes, a surgical plan 2, a 2-phase surgery, inclusive with implantation of intracranial EEG electrodes, monitoring in an ICU, a second surgery to resect or disconnect the epileptic focus and to remove the electrodes. These colleagues emphasized that there is need for a very strong interest and support from the local medical community and administration for the partnering with a foreign medical team. The major challenge, as they say, is maybe the reluctance of some members of the local team to embrace this partnership. Finally, I'd like to take this opportunity to announce an upcoming publication, probably in March of this year, by Springer Nature, of a new book that I finished to edit together with my colleague Olaf Schijns from Maastricht in the Netherlands. And I thank you for your attention.
Thank you, Professor Dirk, for the presentation. I introduce our panelists for the discussion. I'll start with Professor Glenn Sambi, who serves as Professor of Neurosurgery and currently the Dean of Medicine at the University of Kinshasa. He successfully served as head of the Neurosurgery Service and head of the Department of Surgery at the University Clinics of Kinshasa. And he trained at St. Luc Hospital of the Catholic University of Louvain in Belgium and the Red Cross Hospital in Asaikawa in Japan. He holds a PhD from the University of Kinshasa in 2015 and is currently a full professor. He's also vice president of the Congolese Society of Neurosurgery and a former vice president of CAANS in charge of Central Africa, member of the Spine Commission of CAANS and North American Spine Society, and the program director of COSEXA at the University Clinics of Kinshasa, and member of the Society of French-speaking neurosurgeons, as well as the WFNS. Professor Glenn Sampi, thank you if you can go ahead. Professor Sampi.
Okay. There are problems. Yeah, it's good now.
Thank you.
Okay, so I thank you very much, Professor Musara and all colleagues. I thank also Professor Van Roost for a presentation. That is very important for us. Firstly, to remember the process of eligibility of patients for epilepsy surgery and how to build the teams in our context. To build a team is a very, very great problem in our countries, I won't say African countries. I work, myself, I work in epilepsy refractory center at Belgium with Professor Raftopoulos. But when coming back in my country, I was idea to develop one epilepsy center, but difficult was firstly for imaging, because when I come back at 2012 from Belgium, there are no MRI in my country. We had in this period only CT scan. This is the first difficulties. The second was team from neurologists, because in our country we have one neurological center who train people for general neurology, but not physician directly trained by epilepsy particularly. So this is a great difficulty, but we can say now we have MRI, and last year we introduced STEREOTACTIC surgery and neuronavigation. So we discussed with neurologist team to have training for epilepsy, so people who are focused on epilepsy can contribute to build our team to have epilepsy center. The experienced Professor Van Roost show us from Uganda and Panama is very, very important for us to have a model. We can start with relatively easy fix, like lesional epilepsy, before to go to very, very particular epilepsy, like to use subpial transection or grid deconnection. But from lesional epilepsy, if we have a great team, we can start to have progressively treatment for epilepsy. Because if we consider that around 1% of people or what people can have
Thank you, Professor Hamdi. Our next panelist to discuss is Professor Mehdi Jamour, who is a full professor of neurosurgery from the University of Monastir in Tunisia. He's also head of the Monastir Neurosurgery Department in Tunisia, past president of the Tunisian Neurosurgery Society, president of the Tunisian Neurosurgery College, president of the Maghrebian Federation of Neurosurgical Societies, and president-elect of the Pan-Arab Neurosurgical Society. He's also second vice president of CAANS and the president of the CPD committee of the Neurosurgery Arab Board, as well as a member of the executive committee of the French Language Neurosurgical Society. He's also a member of the WFNS Audit Committee. Professor Mehdi Jamour, you can come in. Thank you.
Good evening, everybody. First of all, thank you for your kind invitation. We thank Professor Dirk Van Roost for its excellent presentation, and also Professor Hussein Hamdi also. I will say that functional neurosurgery include a wide spectrum of conditions such as movement disorder, epilepsy, chronic pain, spasticity, and neuropsychiatric illness such as depression, obsessive-compulsive disorder, and addiction. And we should manage this problem with a multidisciplinary team. We should highlight the importance of the multidisciplinary team in functional neurosurgery. They are critical and to optimize treatment for complex and often irreversible neurological condition like DBS. They combine expertise from neurosurgeon, neurologists, radiologists, psychologists, and rehabilitation specialists, and all level of staff to create personalized, safe, and effective treatment plan that enhance patient outcomes and quality of life. Also, we should create center of functional neurosurgery in Africa, and the minimum technological and infrastructure need in each center. Each center should have equipped with imaging, MRI, CT, stereotactic frame, neuronavigation system, or DBS equipment with well-trained neurosurgeon. The problem in Africa is the lack of or acute shortage of specialized neurosurgeon or functional neurosurgeon, exacerbated by the inadequate infrastructure, lack of MRI, CT scan, operating microscope, and this is as African, we should promote this condition in Africa. In each country, we should create a center of functional neurosurgery, or at least epileptic neurosurgery, and promoting research and collaboration. And we should encourage the international partnership, as said by Dr. Dirk Van Roost. We should create opportunity for young neurosurgeons through scholarship, facilitating knowledge and exchange. And we should also equipping African country with specialized equipment and the new technology to do this kind of surgery, and improving infrastructure of hospital and unit of dedicating to functional neurosurgery. And we should encourage our this specialization by creating a diploma or master of functional neurosurgery in Africa. And thank you for
Thank you very much for the contributions given. Now, I want to open up the discussion to other members of the panel who may have some contributions into this topic. You can maybe raise your hand and we can be able to see. Or at least write your contribution so we can be able to read it.
Prof. Aaron Masaru, the epilepsy section was quite interesting. If I could please just pose a question to Professor Ensslin. He was able to establish an epilepsy center that services quite a large portion of the South African population. So based on the talks that were given and our other panelists' comments, can you probably just give a bit of insight of how long it took you to start up the practice? And any advice for the young neurosurgeons specifically? Thank you.
Thanks very much, Dr. Tangri. Yeah, I think the important thing, like Professor Van Roost said, is there is a few examples of places around the world in low and middle income countries that has done it. We've been doing epilepsy surgery in Cape Town for about 40 years already. And in the past 14 years, I've escalated the service from where it has been in the past. I think the important thing is that nothing comes for free anywhere. It's not a system. Nothing in neurosurgery will happen if you don't have a local champion. So it's hard work. There needs to be someone that is dedicated to a specific cause, dedicated to develop the technical skills and the philosophical skills that comes with treating conditions like epilepsy. So the neurosurgeon in a low and middle income country needs to understand that they need to do the roles of a neurologist or epileptologist in other countries. The multidisciplinary team is often led by or has to be led by the neurosurgeon. So you as a neurosurgeon needs to have skills in EEG. You need to understand semiology. You need to understand what all these different things that the epileptologists usually give to the neurosurgeon in developed centers. You have to understand what that means, and you have to guide your team to develop those skills. But at the baseline of it, it has to rest on your shoulders. So it's hard work, but you need a local sort of champion or a local person that takes all of those skills on and understand that epilepsy surgery doesn't come with a recipe. The patient doesn't arrive on your desk with a specific set of things that you have to just lines where you have to cut. You have to understand the disease and you have to know how to interpret all these different information pieces that you get and then formulate a specific plan from that. So it takes time. I think someone has to, it's not, you don't arrive at the unit and just start doing epilepsy surgery at the level that Professor Van Roost does it in Belgium or anywhere else in the world. It's a journey that you have to take part in. And one of the speakers also mentioned that about the MRI scan, and that I think that's part of a problem in Africa in general, is that people travel to places where they learn a way of thought. With respect, it's not going to be very helpful to you if you go to the Cleveland Clinic to learn how to do epilepsy surgery, because you're not going to be taught how to do epilepsy surgery without having MEG, without having stereo EEG coming out of every spot of a cranium, and the local construct or the local relative lack of information that you have will be sort of hampering your progress when you come back. So it's important to go to certain places, learn these different techniques, learn these different philosophies, but always remain cognizant of where you are going back to. So it's no use going to a place that has only access to MEG and you're not going to get taught as to what that unit did before they had a MEG. So whenever you are at that unit, you have to go through that whole process of learning how to think about that. What is the place of magnetic encephalography, for instance? How does that help that specific unit formulate their semiology pattern and their epilepsy hypothesis as to where's the seizure onset zone, where does it spread to, what is the network of the disease, like Professor Van Roost said, because epilepsy in Africa is a network disease the same as it is everywhere else. The fact is just that where you are based, you don't have the luxury or necessarily the level of tools to evaluate that in the same way that you did wherever you trained. But you have to constantly bring that knowledge back to your local circumstance. And you just have to work harder to understand those older techniques, the basics of really understanding clinical interpretation and semiology remains king. As soon as you start to depend too much on special imaging and everything, you lose the real wonder of the amount of knowledge about a patient's epilepsy, for instance, that you can learn from just paying attention to their semiology, looking at videos that the family takes of when the patient has seizures. And then there is two basics. With the ILAE, we've described topics in the past, but the bare necessity that you would need, that we at the ILAE feel is important, is you at least need a telemetry, an inpatient telemetry, video telemetry service with a scalp EEG, and you need an MRI scan. Yes, there is maybe certain things, and we can discuss that if there's time later, that you can treat maybe based on a CT scan, because you can see where infarct has been. You can see whether a patient has post-stroke hemispheric disease, and if they have diffuse conditions, you can pretty much base your decision on whether they need a hemispherotomy or not, based on what the child's CT scan looks like after neonatal stroke-related epilepsy. And certain tumors, we can localize them, and if it's in the temporal lobe, you can maybe do surgery based on that if the semiology matches it. But for epilepsy surgery proper, you need at least an MRI scan. It does not need to be a 9 Tesla scan. I think with a 1.5 Tesla scan, you can already do a lot of wonderful things, but your clinical mastery needs to remain up to date. And then the sad reality is you cannot become an epilepsy surgeon if you can't do very good, very safe, basic tumor surgery. You cannot have people that struggle to manage basic neurosurgical cases and have poor outcomes with those, and then start to envelop into epilepsy surgery. It needs to be teams that are experienced and has good outcomes with the techniques that is available to them. And then one starts to slowly but surely build. And don't start off with, like Professor Van Roost says, don't start off with the MRI negative epilepsy cases. We know that the chance of cure in that cases is already significantly lower than the epilepsy if there is dysplasia or changes visible on the scan. So start off with the temporal lobectomy cases, start off extrapolating your skills from the callosotomies, hemispherotomies, and then you start building into these more network disconnection type of conditions. But I think it is a process, and the examples that Professor Van Roost has mentioned from those studies, the group in Uganda that we're supporting together with the group in Chicago, is a good example of that. How once you have that basic set of requirements, then partner with local people and international people, but that those who have a respect for the local circumstances, and you start building your experience. But you keep on involving people to help you check your findings and check your plan. Don't just do it on your own. It's no man alone in functional neurosurgery. You need a team, as has been discussed. That team does not necessarily be on the same continent or in the same country as you, and international collaboration really comes into play there.
Thank you so much for that contribution. It's quite important, when you mention the importance of a team, because of the nitty-gritties of the issues involved, the diagnosis coming through neurosurgeons as well as neurologists, and some of the treatment coming through other areas of specialty. Let's hear from Professor Jeff Ntalaja from the DRC, who's got his hand raised.
Thank you, Dr. Musara. I'm so happy to be in this meeting, and I see what is the importance of functional neurosurgery in Africa. You know that when we talk about epilepsy is the disease, is a large field in Africa. More than the problem is more than many countries, they didn't have a team like they talk. We can have diagnostic, you can have clinical diagnostic, but we have also the problem now for the functional, for example, how many countries they can have a frame of STEREOTACTIC. I think that we have less than 20% of countries in Africa, they have it. That is the big problem also we have in Africa. And the second, in this meeting, it was very interesting to have this meeting because now many countries, they know that they can have the collaboration of the other country to help them to organize this field in their country with the collaboration with, they talk about Uganda and the other country working with New York. We can have also the team of Africa. We can work in another country. That is the good news for us. With this meeting, we know that we can now find some team who can help us, because in all of our country, we have a lot of patients with epilepsy, but sometimes refractory epilepsy, but sometimes we didn't have a solution because we didn't have the team to do it. That is, for me, it was very, very interesting to have this meeting. And I think that after that, in CAANS and the other countries, we can have maybe some center in Africa who each country who needs, for example, help to organize the team of epilepsy, they can ask this country or this team working for that field. Thank you.
Thank you. Thank you so much for that contribution. I'm sure hearing Professor Nico Estlin speak, I'm sure those who would want that kind of assistance, I'm sure you'll probably be willing to assist. Thank you.
Definitely.
Now, we have got a question from Dr. Joshua Mwambali from the Congo, who's asked two questions. Are there any minimally invasive epilepsy surgery techniques that use an endoscopic approach? Would these techniques be cost effective? Maybe this question is trying to say, can one just go endoscopically without a frame during an epilepsy surgery? And then the second question, how long does it take to be trained as a functional neurosurgeon to get the core competencies needed? Maybe let's hear from our panelists.
Shall I answer?
Yes, please go ahead.
Well, as for the endoscopic approach, I have only one application in my mind, and that is not as much for placing electrodes, but it is an option for the treatment of a hypothalamic hamartoma, besides other options that also exist. So one option is to go transventricularly towards the hamartoma and ablate it by electrocoagulation, visible through the endoscope. The other options, however, are gamma knife surgery or stereotactic surgery in general, or laser interstitial thermotherapy, which is very expensive because of the disposable material, or electrocoagulation, just stereotactically guided without endoscopic feedback. That is one single application I see for endoscopy in epilepsy surgery.
Thank you
I
for
see
that.
that the same colleague posed another question: how long does it take to be trained as a functional neurosurgeon? Well, that depends very much of the exposure one has as a fellow or as a trainee within the center you go to or you are trained at, and thus also by the volume of turnover in that center. And of course, for the specific domain where you want to be trained in, if it is epilepsy surgery, well, then the exposure to other fields, just as, let's say, stereotactic radiosurgery or pain or movement disorders, is not that important. But if you choose to be a functional neurosurgery in the field of movement disorders, you should choose the department you go to for training or for fellowship exactly on purpose. That's my my response.
Thank you. Professor Ernst Lynch, and I see your hand is up.
Thank you. I think that's a beautiful answer that Professor Van Roost gave. Just sort of in addition about the endoscopic techniques, there are people pushing that boundary in terms of epilepsy surgery. Sarat Sandra from India is doing hemispherotomies via endoscope. Sandy Lamb from Chicago is pushing the same thing, and people are doing endoscopic temporal lobectomies. But I think that is not where you should start off when you do epilepsy surgery. I think the important thing with epilepsy surgery is, again, like Professor Van Roost says, it's a network disease. Anatomy matters a lot, and your exposure matters, and your understanding of dealing with tissue matters. So one should not even consider starting with endoscopic surgery techniques for epilepsy. It's important to do open techniques, and then we'll see in future, because already there's a lot of incomplete disconnections and cases like that coming to the fore in units where modern sort of first world units where they do endoscopic techniques. So I think one has to not equate endoscopic techniques with epilepsy surgery. Definitely not in the early period of your career. It's you're going to shortcut yourself in the long run, because developing that set of skills, I think, with open surgery is so important in building experience and techniques when you go further. So I agree with your answer about maybe for hypothalamic hamartomas as well. That is also not the typical technique that one should start off with when you're developing a center. The nuances of even that endoscopic technique is quite specialized. And so I think early in probably one's career, endoscopic technique should not even be on your radar when you look at epilepsy surgery. And then I think exactly like Professor Van Roost says, your time depends on your baseline, where you start off from. It is a super specialty, so you should spend time, become a very good general neurosurgeon, and then you start layering functional neurosurgery on that. A model which some of the countries, for instance, the Scandinavian countries, they would very early in their registrar time already start doing functional neurosurgery, and then can't, as an example, clip an aneurysm or can't remove skull-based tumors. I think in conditions like epilepsy, it's exactly those other techniques and other skills that you have as part of your armamentarium as a very good general neurosurgeon that makes you a very good epilepsy surgeon. And I think that is important. So it does take time, but it should be on top of your general surgical training.
Thank you for that contribution. So it's clear that yes, there are some procedures which can be approached endoscopically, but don't make it the entry level of trying to learn endoscopy. It's more super specialized endoscopy work. I'm seeing Professor
I might
Jeff.
perhaps even give some more comment on this question, because it also is related to what is being discussed in the literature, what is needed to be good and to remain good in epilepsy surgery. And this question has been linked to the turnover at a specific center. And there are some vague definitions about the number of epilepsy surgeries that have to be done per year in order to qualify as a low or a high or a very high turnover center, with numbers below 15 per year as a low volume center, above 15, but that is controversial. Some also say more than 50 epilepsy surgeries per year, and a very high volume would be more than 100 epilepsy surgeries per year. Well, within this discussion, there needs to be done some nuances, because, as Professor Enslin also said, epilepsy surgery is not something on its own. It is good to have the other neurosurgical skills that are needed to do tumor surgery, to do vascular neurosurgery, because it is a kind of cross-pollination between those subfields. And if people contend that 15 epilepsy surgeries per year would be rather insufficient, it is not really true, because those neurosurgeons who do 15 epilepsy surgeries a year, for the remainder of their time, they do general neurosurgery, probably aneurysms, probably tumor surgery. And so their skills are very much developed also in those types of neurosurgery. And these types of neurosurgery also serve to do good epilepsy surgery.
Thank you. Professor Ntalaja, I see your hand is up.
Thank you. I forget to Nana. Is not.
Oh, okay. So that's an old hand. That's fine. I think I see no further questions and no further hand is up. Let me hand over then to Dr. Lekuya.
Yeah, thank you. Really, it was a great session. Before I just pass the floor to the president. I think the president is not there. We have the president-elect of CAANS is among us. Is going to close the meeting at the end. So I first remind all of us that who subscribe, that we are going to send again different emails for future opportunity of CAANS educational sessions. We really appreciate today's session. I have more questions that I wanted to do, but I think because of time, I would also stop by there. First, I will call our president to close that session.
Thank you, Professor Lekuya. Dear colleague, moderator, speakers, panelists, and dear participants. On behalf of CAANS, it has been a privilege to witness this excellent section of stereotactics and functional neurosurgery in Africa. Today's discussion have shown that this field represented a promising field to neurosurgical care in our continent. That need to be built not only on technology, but on strong foundation training, multidisciplinary collaboration, and sustainable system adapted to our reality. I would like to sincerely thank all our speakers and the participants to their valuable contribution and engagement for this meeting. 3 key recommendations emerge for this session. First, we must prioritize capacity building through structure training and mentorship. Secondly, strengthen collaboration between institutions and the country to accelerate expertise of this field and improve patient access. And third is to develop functional neurosurgery center through collaboration, scalable models, and supported by research and share experience. CAANS encourage the creation of regional network that connect centers, promote education, and advance African-led innovation in functional neurosurgery. Let this session let this session make not an end, but the beginning of stronger cooperation across Africa. Together, through partnership and shared vision, we can expand access to safe and modern neurosurgical care to those who need it most. Thank you for your commitment to advancing neurosurgery in Africa, and the meeting is adjourned. Thank you for all of you.
Thank you, Mr. President.
Thank you. Thank you very much.
Thank you.
Thank you.
My greetings to all of you. Bye-bye.
Bye-bye.
Thank you.
Bye.
Bye-bye.
Thank you. Bye.
Bye.
Bye. Thank you.